So let's go to the next panel. If for those who want to take a bio break, proceed. We're delighted to have Dr. Stephen Peskin with us today. He is the Executive Medical Director for Population Health from Horizon Blue Cross Blue Shield. We're delighted to have you, Stephen, who's asked already some wonderful questions. So Oliver, if you can queue up Steve, that would be great.
Terrific, thanks so much. And I'll go fairly quickly because I probably is oftentimes the case, a few more slides than the 20 minutes or so that I have available, and certainly look forward to answering your questions. So what I thought I would do today is really focus on two practice-based research projects that we did and reflecting on what other people said about the predominance of this work being in primary care, but certainly shouldn't exclusively be. Both of these projects were done in primary care, one with one independent practice with 9 locations called Vanguard Medical Group in Northern New Jersey, and one with quite a number of Rutgers, Wright-Wood Johnson practices. Dr. Anderson, you'll be pleased to know that focused on a grant through the Wright-Wood Johnson Foundation under the aegis of the American College of Physicians, my professional home. So I'm a general internist, still a real doctor, one afternoon a week at a FQHC called the Eric B. Chandler Clinic, where I precept residents in internal medicine, was there on Tuesday, and then Executive Medical Director of Population Health Transformation at Horizon, been at Horizon for about 10 years, and also run internal medicine grand rounds at Penn Medicine, Princeton Health. So that's those are my kind of primary jobs and side hustles. So again, going to start with the work that we did with Saul Wiener and Alan Schwartz and their team out of Chicago, which is really cool stuff called Unannounced Standardized Patient Directly Observed Care, or in the parlance of marketing, Secret Shopper. Next slide. So the impact, again, acknowledgement to Saul and Alan and I3PI and the Robert Wood Johnson Foundation and the American College of Physicians. We could go on to the next slide. So this work really informs how we look at the healthcare that's being delivered. We know about HCAHPS and MGCAHPS and Peskin and on and on and on, and patient satisfaction surveys and putting notes in boxes or sending emails. When I had this socialized to me, and the researchers convinced me that this is a far more profound and meaningful to the healthcare practitioners, whether she be a physician or he be an advanced practice nurse or PA. So next slide. So how reliable is the information? Medical records, lots of false negatives when physicians don't document, lots of false positives. We know about the drumbeat of check the box, check the box, check the box, whether you're in Centricity or Epic or Cerner or EMDs or eClinicalWorks. And then patient surveys have a significant amount of selection bias and socially desirable response bias by persons when they're filling these things out. Next slide. So what current measures miss? They miss some aspects of screening. Is there effective and efficient transfer of health information from the healthcare professional to the patient? Is diagnostic acumen really included? Largely not. Well, certainly with chart reviews and things like that, which are much more laborious and so forth. Critical signs and symptoms, does the clinician spot abnormal findings, and contextualization. So Saul wrote a book about contextualizing healthcare. Does the clinician pick up on cues, challenges? So someone says, well, you know, I lost my job, and the doc says, well, that's too bad, and kind of moves on and doesn't really, or I lost my insurance, and doesn't really contextualize that as well. Hey, maybe they're not going to be able to afford anything, including their medications. Next slide. So what we did was we had actors trained and by medical schools, and we know about these things with the OSCEs and other times that trained actors are used with medical students and residents, simulated patients, and this work was done incognito. That said, the all of the under an IRB, all the practices that participated in this work were absolutely aware that it was going on. It wasn't 60 Minutes ambush journalism. The USP completes a post-visit checklist. The unannounced standardized patient may also carry a concealed audio recorder, and physician note is downloaded. So again, this was all on the up and up with the practices, and I was privileged to have this oversubscribed. So we had more clinical practices raise their hands than we had available slots. Next slide. So USP can uniquely assess wayfinding. Again, I mentioned consumer effort to Dr. Elnahal, and where I was going with that, it's really, really difficult to navigate the health insurance industry, the health industry. If you've never read Ms. Bennett's book, The Cost of Hope, Two Masters Prepare People and their frustration in navigating the healthcare system for her husband, who subsequently died after a courageous 6.5-year battle with cancer. Communication, preventive care counseling, patient experience, documentation, over documentation, under documentation, documentation fidelity are all relatively uniquely assessed by the USP or secret shopper. Next slide. So again, we were looking for some specific targeted behaviors with Horizon and our value-based programs, and again, around fidelity of documentation, and also looking at cost as well. Next slide. So these were the areas we were looking at: prevention and screening, cardiovascular disease, diabetes, overuse, inappropriate use of antibiotics or appropriate use thereof, access, risk-adjusted utilization was part of the rubric, and behavioral health, higher rates of screening for depression using an appropriate tool such as the PHQ-2 or 9. Next slide. So conditions, we looked at tobacco counseling, tobacco cessation, depression screening, breast colorectal cancer screening, medication adherence and diabetes, and management of chronic low back pain, with obviously with the focus the past 7 or so years with avoidance of opioids being now top of mind for clinicians. Next slide. So some of the things to implement to achieve goals: medication adherence, approve diabetes control, identify and manage depression appropriately, what can go wrong, overlooked barriers to non-adherence with depression missed due to incorrect screening or overlooking of positive signs, cancer screening, increased screening, and then again, overlook common misconceptions about cancer screening that reduce screening rates among consumers, among patients. Next slide. So with chronic pain, effectively manage non-cancer pain, again, looking at opioid prescribing versus using education, giving out sheets to patients on exercises. I know I've shown a lot of patients how to do the yoga position, down dog, either on the floor or with a chair assistant, to help with low back pain, which is oftentimes due to tightness in the gluteal muscles and hamstrings. Tobacco cessation, overlook tobacco use or advice on quitting without proposing evidence-based strategies is what can go wrong. And then again, documentation accuracy, record clinically significant information discussed during encounter versus neglecting to document clinically significant information. Next slide. So here we have the unannounced standardized patient heat map, 217 visits for trained patients with 1 to 2 focal conditions, 59 clinicians, 22 practices. Here you can see, a preponderance of concentration in the most densely populated area of northeastern New Jersey, but we had some in other areas, including all the way down in Cape May, as well as Monmouth County and Middlesex and Somerset. In each visit, the USP completed checklist, and visit audio recordings and provider notes were coded. After 2 baseline visits, feedback was given to the healthcare professionals. I'm really pleased to say that clinicians took this feedback well, and many of them showed evidence of positive change after the intervention, both at the individual, her level or his level, and also related to feedback to the practice, which might be a lot around things like scheduling and telephone manners and that sort of thing. Next slide. So pre-visit, post-visit feedback, as you can see around chart fidelity. You can look at the study group. This was done from October to December 2017, and then 9 months later, July to September 2018. So substantial numbers of data points here. So we feel like the study was sufficiently powered, and we did publish in a peer-reviewed journal from this work. For diabetes and low back pain, we also had access to patient attributed costs based on our Horizon Blue Cross Blue Shield algorithms. Next slide. So provider performed expected care based on announced standard advice patient checklist and 46% of items. Feedback visits and 50% in post-feedback visits. Significant improvement in areas include smoking cessation, managing chronic low back pain without opioids, and depression screening. And here you can see where the results were largely positive, but not entirely so in every area that was looked at. Addressing diabetes medication non-adherence really didn't move, and identifying resistance to cancer screening actually not statistically significant, but dipped down a bit. Certainly some areas like smoking cessation, significant improvement, and also managing low back pain without opioids. Next slide. So observed frequency of target behaviors recorded by the unannounced standardized patient, heard versus encountered in the medical record, documented pre and post. So again, there's some discordance in these areas, and we know the chart does, at least in medical legal terms, does reign supreme, and so that is important feedback to the clinicians. Again, whether it be under documentation or over documentation, that is documenting a foot exam when a foot exam was not done. Next slide. So claim costs increased less among the real patients where physicians adopted specific evidence-based behaviors. Claims costs increased for smoking, addiction, low back pain, and prevention where physician adopted recommended behaviors would be expected to increase cost. So not all costs are bad. Some are appropriate and we're looking for. Next slide. So again, some limitations of the study: selection bias, study practices all volunteered, and we had lack of access to prescription claims. We as a payer have less than 50%. A lot of our plan sponsors elect to go with a PBM that's not the one that we use. Next slide. So key takeaways: unannounced standardized patients identify clinically important quality deficits. Again, both underreporting and overreporting. Feedback based on secret shoppers collected data leads to better quality as measured by the follow-up visits, and unannounced standardized patients drive quality improvement. So certainly I'm a big fan of this work of Saul and Alan, and if any of you on the call would be interested in connecting with them, I'm more than happy to make that connection. I have no financial interest, by the way. So other than they're two very nice fellows and doing some serious and I think very important and meaningful research. The next slide is the second topic that I'm going to go through in about 8 or 10 minutes. So we worked with Dr. Edwin Fisher, Professor, Department of Health Behavior, Global Director, Peers for Progress, and at one of my alma maters, the UNC Chapel Hill School, although I did not go to the Gilling School of Global Public Health. Janet Dooney, one of my friends and co-travelers in population health in the state of New Jersey, who leads efforts as an RN for Vanguard Medical Group, and Melinda Peoples from a company called WellDoc based in Baltimore, Maryland, and they did the sort of the digital connectivity for this program. So this program, next slide, was intended to answer the question or look at the issue of the social connection. So human beings are more effectively and happier when they hear from someone that they can talk to about personal matters, who care about them. I'm reminded of a grand rounds from this past Tuesday that my friend Dr. Steve Trasiak, chairman of medicine, Cooper did, and the work that he's done on an area called compassionomics, where he's rigorously studied that compassion leads to better health outcomes and higher levels of physician satisfaction and lower levels of burnout. The risk of death associated with social isolation is greater than the risk associated with cigarette smoking. I think the study from England was equivalent to roughly 14 cigarettes per day. So we decided to look at, with working with Ed, the impact of using peer coaches. So think about the population I see at Chandler. So a middle-aged Guatemalan female speaking to another middle-aged Guatemalan female versus a 29-year-old South Asian resident. And that's no disrespect to the 29-year-old South Asian resident, but she or he may not speak Spanish or only very little bit as I do. And that ability to connect with someone on their own terms, in their own language, around their own kind of contextual history, social history, food choices, and the like. Next slide. These are not professionals, often have the health problem. For example, in our work, I think the vast majority of the peer coaches were persons with diabetes, share perspectives, experience. People believe them because they are like me, can teach how to implement basic self-management plans, healthy diet, physical activity, and they have something that a lot of clinicians don't have, you know, on the proverbial hamster wheel, which is they have time and can be more relaxed and conversational. Next slide. So engaging hardly reached peer support reached over 85%. Low income people, Latinx with diabetes, single moms, reaching populations, improving hemoglobin A1C and blood sugar, integrating behavioral health and peer support, reduce distress and likelihood of hospitalization. That was a study done in Hong Kong and published in the Journal of the American Medical Association in 2014. Next slide. So 4 key functions: assist in daily management, social and emotional support, kind of an ongoing link, person-centered principles, choice and empowerment, shared decision-making, being very collaborative, care adapted to the needs, interest, and preferences, importantly, of the person, and effective at humanizing peer support. Next slide. So this just shows kind of some of the key functions. I'll let you all just kind of read over this because, again, I want to be respectful of time and give time for my co-presenter and also time for questions. So again, the check-ins, the monitoring, specific reminders of care as needed, and then the data was all coded. Next slide. So this was how we organized it. So it's one medical group in New Jersey, a fairly large primary care group that also has a few subspecialists and has embedded advanced practice behavioral health nurses and does home visits and some other cool stuff. So physician, care coordinator, health coach, and then Blue Star and WellDoc is the digital platform. Again, not specific, they work with us on this. There are many others out there. So this isn't, again, necessarily to endorse one, but this was the one that happened to be the one that Ed wanted to use for this particular study. And it did have some power and improvement by, again, using the combination of in-person, obviously way pre-COVID, or telephonic, and also some digital touches. Next slide. So this just shows you how the digital health, peer support were integrated for the around whole person care, self-management support with nutrition, digital guidance, clinical decision support around care management, and again, making sure that we took a very much an informed or shared decision-making process with the consumer, the patient, herself or himself. Next slide. The design, single group, pre-post, continuous quality improvement framework, quality evaluation, coach contact notes, post surveys, again, and claim data was being collected along the way by Horizon. Next slide. Health coach training supervision, 16-hour initial training, weekly conference calls for troubleshooting, clinical oversight from care coordinator, direct supervision by program manager. So the peer coaches did have, there was some important training and oversight for these peer coaches. Eligibility criteria, adult patients, hemoglobin A1C greater than 7.5, having a smartphone with internet-enabled computer and able to read and write in English. So there were certainly some constraints that this slide elucidates. Next slide. So it just again goes over the study protocol, N of 200, onboarding, coaching contacts, and then the follow-up is delineated and with biweekly contact and so forth. Next slide. So structured telephone interviews, 15 patient interviews, 5 staff interviews, 2 health coach interviews, behavior changes made, helpful features of coaching from Blue Star, and quality of care improvements was the qualitative evaluation of this program, which we also did publish. Next slide. Pre-post hemoglobin A1C, you can see health coach utilization was evaluated, and then Blue Star intervention, digital intervention was also looked at with pre-post measures of hemoglobin A1C, blood pressure, lipids, and BMI. Next slide. So here we have the results of patients enrolled and how many contacted. You can see that the number average of 6.5 entries per patient per week. You can see that what the average hemoglobin A1C was, and the average age, and the gender, high program satisfaction, high willingness to participate in interviews. Next slide. And again, you can see that the technology did support and undergird the program. So the WellDoc Blue Star technology or digital support was important with the certified diabetes educators, the coaches, the healthcare professionals, the physicians, endocrinologists that might have been involved in the care and care coordination. Next slide. And then again, this notion of leveraging patient generated data to better inform health decision making and the activities, importantly, tailoring interventions by healthcare professionals. So 2 programs that I thought were very resonant for today around practice-based research, one done with quite a number of practices scattered around the state of New Jersey, and that was the unannounced standardized patient or secret shopper or directly observed care, and the other one, the application of peer coaches. I would also mention that we do have a collaboration with Rutgers Medical School and Dr. Strom, a collaboration Horizon. We're doing things in subspecialty care, such as with Dr. Jalbot and multiple sclerosis, and environmental science, environmental health, as well as in cancer care and some other areas. So that we're very pleased with that. We had a bit of a COVID hiatus from that research collaboration, but we're picking things back up, I think, next month. So thanks for your time and attention, and look forward to taking questions either now or after we finish this segment.
Thank you so much, Steve. Questions from the group?
I have a question, Steve. Thank you so much. And part of what we're all trying to do is to disseminate best practices. So a couple of examples that you presented about these interventions and their effectiveness. How do we instill this, in our practice environment, in our operations, in the culture of our physicians and how they work? Some of it is maybe through a CME type of an approach, but truly making change happen fast is what we're all challenged with to get these best practices out there and really happening in the practice environment.
Yeah, it's a great question, and I would say that's a gap for sure. The USP is not an inexpensive intervention. We have socialized it. We haven't continued to fund it, quite honestly. And so doing programs like this and stimulating leaders like yourself to think about it can be revisited. I think peer coaching has gotten a lot of traction, and then our study is one of many about the use of peer-to-peer coaching to really enhance. I know a number of practices have, in addition to integrated social workers or behavioral health professionals, have embraced the notion of peer coaches or health coaches in the context of CPC Plus, and now Primary Care First and other alternative payment models. So I'd say our work, while a modest effort with one practice around diabetes, is I think we have seen, Andy, that take a greater hold in not only in primary care but in some subspecialties as well. The use of peer coaches. But happy to visit with you about this in the future as well.
Thank you, Steve. Other questions from the group? Well, Steve, thanks so much for joining it. I can share on a personal note, working with Sarah Jang over the last couple of years. It's been a wonderful experience, and I'm so delighted that she was able to suggest you to be able to speak with us today. Thank you so much, Steve.